From Sue Kruske, who's going to bring us a very different perspective. Sue's been in town for the AMOSS RHD and pregnancy study. They've had 2 days in Darwin, and I think this is her final commitment while she's here. Sue is a midwife and child health nurse with clinical teaching and research experience in maternal and child and cross-cultural health, particularly with remote Indigenous communities. And she works very much to collaborate and support the health workforce in working more effectively with women, particularly around cross-cultural childbearing practices. And Sue's going to provide us with a presentation around the qualitative research for AMOSS. Welcome, Sue.
Thank you. I haven't actually prepared a PowerPoint, which I think you're probably all happy about. It's late, that you've all been at work all day and you've been listening intently to a great range of presentations, and I've really enjoyed listening to them as well. I'm a very rusty bush nurse. I've been working, I worked in the remote areas most of the 90s, and my very first acute rheumatic fever I'll remember until I die, probably, because I failed to know what I was doing until the mother presented with her 5-year-old for the 3rd time, and the child finally had chorea, and I didn't realise any kids could shake at 5 years old, and I finally got on to talk to a doctor, and of course the child had acute rheumatic fever. So the lived experiences of patients and families with this disease is incredibly powerful, and I'm here tonight to tell you a little bit about the rheumatic heart disease in pregnancy study that I'm involved in. It's an NHMRC funded program that's tagged onto AMOSS, which many of you will know about, and it's largely quantitative. So the qualitative arm is quite small, and it's not hugely well resourced, but it's headed by Liz Sullivan, and the chief investigators recognise that if we're going to do anything around trying to work out how we do this better as a health service, we have to try to access the voices of the women who the disease affects and who we are trying so hard to improve. So there's been a lot of talk about children, because that is the key focus of the area as a program, and I just have to remind us all that if we're going to work with kids, we have to work with their parents, and it's the parents who will decide, particularly with the younger kids, how they engage with the service. And part of my other research interest is around childbearing practices, and I think it's a unique phenomenon in Aboriginal families where the child is very much a determinant of what that child wants. So if the child doesn't want needles, it's going to be really hard for that parent to force that child to have needles. And I think we have to be really aware of the different childbearing practices that we have in remote communities if we're going to be effective. So I digress a little bit, but basically the qualitative arm of the rheumatic heart disease in pregnancy study is trying to find women as early in pregnancy as possible, and then follow their journey through their pregnancy, birth and early parenting or postpartum period to try to get some sense of their experiences as they interact with healthcare. And that's a really hard piece of work to do, because women with rheumatic heart disease live all across the territory. We've got a fairly small budget. Most of our researchers live in Darwin or Alice Springs, so we're doing the best we can. We've only recruited 4 women so far. We're hoping to recruit between 10 and 15. And as I said, it's multiple points of interest as we accompany them on their journey, trying to basically walk in their shoes, and also trying to identify the barriers that they have in engaging with the service. So, as I said, we've had 4 already identified, and 3 of them have had their babies. And we only met as a team yesterday to try to look at the massive volume of data. As you can imagine, if the research assistants are meeting these women at multiple points, they're doing long conversational interviews, because the approach that you use in trying to get these stories out of women isn't sitting them down and actually bombarding them with a checklist of questions, but it's actually having these fluid conversations that the women will allow you to take you to wherever the women want you to go. So it creates large amounts of data, and a lot of it is not relevant to the research questions, but we still have to wade through the transcripts to get our key themes. So I can't tell you too much, but I will share with you some of the things we came across yesterday. I think it's really important for us to understand the women's understanding of the disease process. And I'm sitting in a very informed room of people that know the challenges of working with remote women and remote communities, but their understanding of the disease process is different to the scientific Western anatomical understanding that we all know. And I think we have to be very mindful of trying to unpack and understand what that understanding is without creating negative stereotypes around, you know, these different ways of knowing. So we are, through the interviews, we are finding very low levels of scientific physiological understanding of the causes of rheumatic heart disease. And I think that, again, anyone that's worked with Aboriginal families, if they feel well and if the kids look well, they're well. And I think this disease is so difficult to actually describe at length about how you can feel well, but this stuff is going on inside you and you need your monthly needles to actually stay well. And those ongoing challenges of helping the patients actually understand why they need to come and receive this very, very painful injection once a month. So I think that we hope to understand this differences, but we can all be fairly confident to know that most women and kids that have this disease process don't understand the actual etiology or causation of the disease. As Claire said, I've been here in town for 2 days talking about the project, and Anne Lowell, who's done some fantastic work with the Gallowinkel people in East Arnhem, gave us an overview of a project that she's been doing for chronic disease and understanding the role of the lungs and hearts in chronic disease. And she explained that in East Arnhem, at least, they believe that if you utter something, it will occur. So if we keep saying to these people, if you don't have your needles, you will need heart surgery, it's almost an acceptance that that is their projected outcome. So just little crazy cultural things like that, we're hoping to understand a little bit more and then give that information back to the community, to the stakeholder communities themselves, even in the language we use in trying to encourage prophylaxis. I think the other thing we have to realise is the very complex, socially chaotic lives that many of these families live in. There is high rates of DV, there is high rates of mobility, there is high rates of food insecurity, there is high rates of financial insecurity. All of those things do impact on your ability to engage with healthcare. I think we have to be much more sympathetic to the challenges of getting our clients to present to not only to the local clinic out bush, but then to come into town and receive the higher level specialist care that's so important in this disease process. We did get many, there's many examples in the 4 women that we've got where they're constantly falling through the cracks for silly things where, you know, women are being discharged in the middle of the night without enough access to their medication or scripts to get medication filled, and the research assistants having to actually scramble around and, you know, follow up on behalf of the woman to try to get things like scripts and discharge summaries and transport organised. So, you know, luckily with qualitative research we're allowed to do these things, but it is a difficult thing for the research assistants to manage, to put those boundaries around what, you know, trying to collect data for a research project, but knowing these things are so important for these women to access. So having to actually act as their advocate as in the process of collecting data. I think we realise that, and again, everyone knows this, but the judgment and the lack of understanding by many of us in our health professions for these women's journeys and their quests to actually receive good healthcare, and the unintentional racism that exists in our health service. And we're everyone is guilty of it. I'm guilty of it. I'm sure all of us in the room are guilty of it. Some of us are more guilty than others, but I think we have to actually develop some kind of triggers or red flags to develop where these women are coming up against basically racist attitudes of individual professionals, but also this lack of empathy or lack of understanding of trying to actually do positive discrimination, put in barriers that put in enhancers that actually allow women to negotiate this crazy world that is the health system. In spite of that, women are incredibly resilient, they're incredibly tolerant, they're incredibly aware of that they need heart surgery or that they need to get their monthly needles. So I think, again, we have to stop pretending or stop thinking that the level of health literacy is so low that we don't tell women anything. And Angela also explained yesterday that the women in East Arnhem say, stop giving us the simple story. We want the whole story. We want the deep story, and then we'll work out what we do with that thing. And having simplistic messages is different to having very simple messages. So I've learnt lots over the last few days, and I think we will all continue to learn as we follow these women who are so generous in sharing us as we accompany them through their pregnancy, birth and postpartum period. But I don't want to diminish the hard work that everyone's doing. I don't want to diminish the intentions that we as an industry, as a health industry, are working very hard to improve the lives of children, women, families who have this disease. But I think if we can develop some more empathy and some more focus on the lack of coordination and how these women continue to fall through the cracks, I think that will benefit. So I probably won't share much more with you unless anyone has any questions, but yeah, thank you very much.